All right, chapter 52 talks about nausea and vomiting. Nausea then is the feeling that you're going to be sick. Vomiting then is the emesis, or the forceful emptying of gastric contents. And as they note here, occasionally intestinal contents, especially if somebody has a blockage, you might get fecal matter out of the mouth. And antiemetic drugs then are the drugs that we're talking about that help to relieve nausea and or vomiting. There's a vomiting center in your brain and a chemoreceptor trigger zone that help mediate this gag and vomiting reflex. And so they have input from the cerebral cortex, the labyrinth of the inner ear, and the GI tract, and that triggers the chemoreceptor trigger zone, that puts input into the vomiting center in the medulla. So there's a bunch of antiemetic drugs and anti-nausea drugs on the market. Before we get to that, I just want to say one thing. On page 845 in your textbook, there's a little patient-centered care box on there about syrup of ipecac and poisoning. I'm 100% sure that you guys know this, but syrup of ipecac is no longer recommended for pediatric patients or anybody to take anymore ever. We've taken it off of all formularies and recommendations since 2003. Okay, so it's not safe. Because the person could vomit and then aspirate, and then not only would they be aspirating the vomitus and the acids from the vomit, but they'd be vomiting the whatever substance it was that they swallowed. So not a good idea. All right, so anyway, moving on to 846 are antiemetic drugs. So these are drugs that are used to relieve nausea and vomiting, and they work on some point on that vomiting pathway, right? So anticholinergic drugs like scopolamine are used for motion sickness, antihistamines, even Benadryl, but like meclizine can be used for motion sickness. Antidopaminergic drugs like Phenergan, Compazine, droperidol, those can be used for nausea, vomiting, even actually for migraines. Prokinetics like Reglan help move things in the right direction. So they a lot of times will stop nausea and or vomiting by kind of getting the stuff to move downward rather than upward. Serotonin blockers, I want you to think of Zofran when you think of those, but these are the drugs that were developed to treat nausea and vomiting associated with chemotherapy post-operatively, and now they're also being used for pregnancy. And then THC, so the pure chemical from marijuana is used very effectively at treating nausea and vomiting associated with chemotherapy, anorexia associated with weight loss with patients who have HIV and cancer, and then other things like multiple sclerosis, chronic pain as well. Again, there's different mechanisms of action where they work, but they all work by blocking one of the vomiting pathways. So they block the stimulus that induces vomiting in that lovely picture we looked at. And here it is again. All right, so how do these all work? Here's the anticholinergics, antihistamines, antidopaminergic, and prokinetic drugs work in this pathway. Prokinetics, serotonin blockers over here. THC, corticosteroids, benzodiazepines over here. And they didn't mention benzos in here, but just by the way, Ativan and Valium are some of the most potent anti-vomiting drugs on the planet. Antidopaminergics, prokinetics, and serotonin blockers here, and then serotonin blockers here. So you can see one of the reasons why we use Zofran, which is their serotonin blocker, so frequently is that it works in the GI tract, the chemoreceptor trigger zone, and the vomiting center to block it, but it doesn't have any cerebral cortex alteration or depression, whereas THC, corticosteroids, and benzodiazepines can all have central nervous system effects, whether it's depression or stimulation. So that's one of the reasons why Zofran is so great. So the general use for each of these is to prevent the signs and symptoms. Anticholinergic drugs, as we say, block those receptors, especially in the inner ear, and then scopolamine being one of them. The other thing that scopolamine is used for is to dry up secretions. So remember, it's an anticholinergic, so it dries things up, right? Patients preparing to administer scopolamine to a patient, the nurses, I guess, it's most important for the nurse to determine if the patient has a history of which condition. So going way back in your brain to anticholinergic drugs and thinking about anticholinergic drugs and their adverse effects or their contraindications. Remember that anticholinergic drugs have a contraindication with glaucoma, right? Antihistamines then are H1 blockers, and they're used for motion sickness, coughing, allergy symptoms, sedation. Dramamine, Benadryl, Antivert, which is meclizine, which is fabulous for vertigo. And then our antidopamine drugs. So these also are antipsychotics, right? Compazine, Phenergan, droperidol. Droperidol has an association with cardiac dysrhythmias, so it's not used as much anymore. But this was, I used to use this constantly in the 90s on patients, and it was absolutely fabulous for stopping vomiting, especially on patients that had head injuries. I loved it. Prokinetic drugs then, like our Reglan. Remember, all of these have that potential for like EPS and tardive dyskinesia, the antidopaminergics and the prokinetics. So a lot of times we give them with Benadryl to block that effect. So patients receiving a continuous tube feed via PEG, which drug would most likely be prescribed for this patient? Well, we want things to move forward. We'd probably use Reglan. Serotonin blockers block the receptors in the GI tract, the chemoreceptor, and the vomiting center. So then we have Zofran being the biggest one that we use normally. And it's affordable and it's great. One of the things that I want you to know about the oral dissolving tablet or the orally disintegrating tablet, the ODT, is that there's two major manufacturers of them. One has NutraSweet in it and one doesn't. So you need to know which one you're giving, because if the person has an aspartame or NutraSweet allergy, you can make them very sick by giving them ODT Zofran. And then our THC preps, so it's the THC from marijuana. It inhibits part of the brain, which alters moods and the body's perception of surrounding, which relieves nausea and vomiting, and instead gives you the munchies. So the patient with terminal cancer has not had chemo for a few weeks and has had no nausea or vomiting since then. However, he's taking dronabinol twice a day. The reason for this is to, what do you think? Why do we give it? So usually we give it to stimulate appetite in HIV and cancer patients, and also to reduce chemotherapy, nausea, and vomiting. So really could be A or D. So Marinol is the trade name, and that's we see actually quite a bit of that around here. Yeah, you know, it's I don't get too caught up in the stigma around it. They're not smoking it. It's available as liquids and it's available as tablets, and you know, it works. It works really well for the people who use it. Patient's 2 months pregnant. She comes to the clinic complaining of severe morning sickness. She's tried numerous non-pharmacological measures to relieve the morning sickness, but they've not worked. The nurse anticipates the use of which anti-nausea drug? So I'll let you look through some of these, but there are some of these drugs are better than others in pregnancy. So this one is category B. The aprepitant, the amend, is category B. But again, a lot of these are used for cancer patients as well. The Emitrol can be used off-label for morning sickness. And the amend is prescribed primarily for cancer. So adverse effects are going to depend usually on where the drug works in the body. Which group of drugs used to treat nausea does the nurse identify as most likely to cause a prolonged QT interval? So this one would be important to know if you have a patient who already has a long QT interval, or if they have a long QT syndrome, or you know, if they're taking other medications like amiodarone or procainamide or something that can prolong the QT. And Zofran is one of them, so serotonin blockers. Ginger. So interesting, ginger gets used a lot for things like motion sickness, like driving in the car, morning sickness, chemotherapy. It does have some adverse effects, actually. Anorexia, it can cause nausea and vomiting and skin reactions. But it can impact the absorption of other medications and increase bleeding risk with other anticoagulants. So some clinicians no longer recommend the use of ginger during pregnancy. So we say you should check with your doctor, your MD, or your nurse practitioner before you use ginger in pregnancy anymore. Patient tells the nurse that he takes ginger almost every day for nausea. It is most important for the nurse to determine if the patient is taking which medication. And so we said that it can change your INR, right? So warfarin. And then things like Plavix, that would be important as well. So look at the history, get a good exam, look at their medications. Is there something that might be causing it? Always check for contraindications and drug-to-drug interactions. The ones that work centrally acting, be prepared for drowsiness. They should never mix them with alcohol, okay? And you could have some orthostatic hypotension as well. For chemotherapy, antiemetics are given 30 to 60 minutes before chemotherapy begins. So remember, just in general, most oral medications have an onset of 30 to 60 minutes. So it's a good rule of thumb to do something 30 to 60 minutes before you need it to happen, right? So give the medication 30 to 60 minutes before you need it to work. Monitor for the therapeutic effects, which would be a decrease in nausea and vomiting, and then watch for any of those adverse effects that we talked about that could happen. I think that's it for this chapter.